We are in the middle of August here. I don't remember what day it is. Wednesday, we're at Newark Beth Israel, and thanks for joining us. We're going to go through our usual. We're going to make it a little bit shorter today because I'm going to the West Coast. I'll see some of you there, hopefully, and things are going well here. Remember that we are no longer sending weekly emails. You just have to go on to our website, www.emsfellowship.com. But what I will do, if I should have time today, we just did a great clinical pearl on what the best paralytic is. Hopefully you've heard us talk about this 1,000 times, but stay tuned. I'll try and send that out sometime tonight. It depends if everything works at 50,000 feet. Let's get started. Who's got an interesting case?
So I had an interesting case this week in the emergency department talking about intubation. So we had a patient who came in her 30s. She was altered. Initially they thought it was an overdose, so she had gotten Narcan at the scene. She was extremely combative, kind of all over the place.
Narcan didn't do anything?
Nothing at all. So 5 minutes away from the hospital, there she was, very diaphoretic, completely unable to follow commands but moving everything, so that was good. And no family was at the bedside yet, so we didn't know what was going on. They were on their way to the report that I got as the ED doctor from medics was that, the family had been with her. They had heard a thud after a friend had left the house, and they found her on the ground unresponsive, but the family had told them before she left, you can't intubate her no matter what you do. And I was like, uh-oh. So,
Why not?
So she had some sort of tracheal stenosis after a prior intubation. So here I am as an ED doctor. I have a patient with a pulse of 150, 160.
And the answer is you can intubate. It just may be a very challenging intubation, and you may need to have a smaller endotracheal tube.
Exactly. So, she was very diaphoretic, and we were eventually able to get a line. And, what we ended up trying to do first was try to just calm her agitation. Maybe this was it was possibly some sort of an overdose, or some sort of ingestion. So
what could it have been, hypoxia from causing her to be agitated?
It could have been. At that time, we couldn't even get an O2 sat. She was flailing around so much. Right. So we went to our friend ketamine, and we gave her.
Perfect. How much did you give?
We gave her. She was a large girl, so we gave her 150 based on her weight.
150. So you gave it IV.
Yeah, we were able to get an IV with a couple of nurses to hold her down. And
okay, so if you couldn't get an IV because she was flailing, we would have given her IM like 5 per kilo. Right?
Yeah, so I would have gone up probably to like 400.
4 plus 100, 500, right?
400, 500. Okay. So, at first it didn't work at all. She was still all over the place. Right. And so we decided to give some more. We gave her a second dose, and after that it calmed her down. We got her to CT scan, and it turned out she actually did have a bleed. So that kind of explained a lot was going on.
What kind of bleed?
It was a frontal bleed, subdural, small. Initially they called it subarachnoid, but, we found out later it was subdural.
Right. So pretty much all subdurals are trauma related, right? We always say pretty much because, it was one of my friends, Jim McKinney. Are you out there? So he always says like old people can sneeze and get a subdural, right?
Sure.
And it's true, right? Whenever you say, there's no trauma, but I remember sneezing hard, right? But odds are you're going to sneeze hard in your life and not get subdurals. But when you get older, because the emissary veins stretch and they pull very easily and cause subdurals, they're certainly at risk for even minor trauma causing subdurals.
Right. In her case, she actually had a prior motor vehicle crash with a prior subdural a while ago, so she could have had some breakdown in that area, gliosis.
And you know that because she had like encephalomalacia on her head CT, or?
Family reported it. She chronic pain issues as well, on lots of pain medication, which is kind of back to the overdose.
Very convoluted presentation with all that.
Yeah, and you're the only doctor there, so it's...
Right. I think I asked you this, but have you guys seen like your first big subdural with a patient who looks like perfect? And you just go, how could it be? You always say it's got to be the wrong patient, but you see all this blood and you see this person sitting there talking to you. And I remember one guy, I can still picture this guy who wanted to get up and leave, sitting on the end of a stretcher, and they told me he had a big subdural. I didn't believe, I thought there was the wrong patient. And I had to go tell this guy who was getting ready to leave that he couldn't leave because he had a lot of blood in his brain.
Why did you scan him in the first place if he looked so Like, what was the story?
Right, it's a good question. That part of the story I don't remember. But you know, if I remember right, I have this vague memory that he had the longest headache of his life. Somebody taught me once you do a CT LP on 3 patients, the worst, first, and longest headache of your life. So the worst makes sense. Never go into the ER and tell anybody you have the worst headache of your life, right? But over the years, I must say that there are people who come in and told me that they have the worst headache of their life, who look perfect, who I didn't tap everybody because I just go, God, this patient is so perfect, right? And then the first, like if you can make it to 70 years old and you've never had a headache and you have a headache today, I'm hard pressed not to do something about it, right? And longest, I people always get surprised when I say that, but if you tell me you've had a headache for 3 weeks and nothing's making it go away, I'm thinking about doing a CT and LP on you, right? Like all the time. So
I don't think I've ever, up until coming here, I'd never had a patient who told me they had never had a headache before until I came out here, and it was like this very sweet 80-something-year-old female with a history of a cranial, like meningioma, like craniopharyngioma or some sort of malignancy, and she's like, and now I have a headache. I've had this cancer for 10 years in my brain, never had a headache, and then today I'm like, great. So now you need to have CT and LP. She refused the LP, but so I ended up actually admitting her because I was like, I at least wanted to watch her overnight and make sure that she didn't deteriorate because she had come outside that 6-hour window where the CT is going to be, mostly helpful. So it was kind of like.
Right. So then you scanned her head and it was negative.
Right. I mean, obviously she had a mass in there, but yes.
Then the question is, like with her, because I guess you're worried about metastatic lesion, right? Is do you automatically do a CT with and without?
Yeah. I did. So that's what I ended up doing. I had the conversation with her up front about the lumbar puncture, letting her know, like, this is going to be the next step because you come in, it's like 15 hours or something after the onset of the headache. And she was like, oh, no, I would never do that. You can't do that. I don't want a lumbar puncture. And I was like, okay, well, then my next recommendation would be that we get a CT angiogram of both the head and the neck because she was saying that it radiated down the side of her neck, and she never normally has neck pain either. So everything came back. The preliminary read was what I got before I signed out, was that it was fine, but I did end up I think I already U'd her.
So CTA negative, then you watch overnight, it resolves, and I guess she's probably okay to go home.
Yeah.
I guess you have to sign her out the next day. Do you have to sign her out AMA the next day?
I don't know. I don't know if it would be AMA and more just a decision, right? Like if you document well that patient is aware of the risks of leaving the hospital, that her headache is not 100% improved, and she does feel better, and she's requesting to be able to leave the hospital. Like if they're alert and with it, I guess I don't really. I don't know.
Especially after 24 hours, especially after being in the RDU, right, and getting a CT angio.
Yeah,
right?
And I've been told even when they sign the AMA form, it doesn't necessarily protect you. Like they can still, if something happens, you still might end up involved in some sort of lawsuit. But
so we do err on the side though of signing AMA forms. But in somebody who goes to RDU for 24 hours, gets observed, gets a CT angio, I might feel a bit differently about the AMA. Don't you guys agree?
Yeah.
I think I would have let her go after the RDU. If she tried to leave the ED, I think I would have made her.
But if she doesn't look perfect, all bets are off, right?
Yeah.
If she doesn't look perfect, then you just AMA her, right?
I'm wondering if she had trigeminal neuralgia, the way that she was kind of describing it, but she wasn't the greatest historian about it because she was saying it sometimes hurts in my face. Anyways, that's a total tangent. But
what's the drug you give for trigeminal neuralgia?
Carbamazepine.
Yeah, it was like.
Right. What's the other name for it? Tegretol?
Tegretol. It was a T.
What's the old name for trigeminal neuralgia?
Tictolero.
Tictolero. Right. Tictolero. And trigeminal neuralgia, just for everybody who's watching, how do they present?
Shock-like pains on one side of the face.
Electric.
Electric salts. You can just tap them lightly.
Right. Then they feel terrible, right?
Yeah.
Somebody asked me a couple of days ago what's that thing called where you have a Bell's palsy and then you have herpetic lesions on your tympanic membrane? What's the answer to that? Somebody sent me an email about this. Ramsay Hunt syndrome. Right, Ramsay Hunt syndrome.
I've seen Hutchinson, but that's the nose.
For everybody who's old enough, that was an episode of ER where Carter and Lucy went to the person's house because Lucy forgot to look at the TM. So the point of here is you always have to look at the TM. You always have to look at the TM when you have somebody with Bell's palsy. All right, that's good. So anything else with that case?
Just the fact that she completely resolved and became awake, alert, and oriented afterwards. So I think at the end of the day, there probably was some sort of ingestion. And then she tried to wake up and ask for a sandwich, and we all thought that was a good sign. And
so if you're hungry, it's always a good sign. You always say you're hungry, and people say,
yeah.
Right. Any other interesting cases?
I had a good pre-hospital case. There's an elderly female I would say late 60s, early 70s. The doesn't speak English family reported pretty much that she'd been sick to her stomach, just some nausea, threw up dark blood a couple times, and she said she wasn't feeling good for 3 days. Goes and sits down to take she was going to go take a shower to try to feel better, and they went to go check on her about an hour later, and they kind of found her just decreased level of consciousness sitting in a chair. She was diaphoretic. We were called. I got on scene with ALS, BLS, everybody at the same time, and she's pretty much slumped over in a chair. She'll answer questions. She actually was alert and oriented times 3, but she was just very lethargic, very weak, didn't really flinch, very diaphoretic. Couldn't get a blood pressure on her with the cuff, so we ended up doing a manual, and it was like 68 systolic, terrible. Heart rate was 80. She had no medical problems other than they reported hypertension. She hadn't taken her meds for 3 days, they said, because she hadn't been feeling well. So otherwise, no medical problems, no previous surgeries, and blood sugar was like 240s. Otherwise, everything else, we kind of talked about sats were fine, but do a 12 lead and it looked fine. The kind of came down to, is this a GI bleed or not? She didn't look like a GI bleed. She didn't smell like a GI bleed. Didn't have any evidence of vomiting blood. It's just reported. And then when we asked, like, oh, is there any around the house, like, to see like what it looks like, because BLS was very excited about looking for it. Family said, no, we flushed it all down the toilet. So so the kind of question came up to, I didn't really have a good explanation. She wasn't on any beta blockers. She was definitely hypotensive. When we actually got her to the hospital, she was her blood pressure was like 72. That was after a liter of fluid. She had, I think, 72 over 38, I think, was her initial pressure at the hospital. So I guess the kind of question came down to was, she didn't look necessarily like an anemia. She wasn't mounting your typical reflexive tachycardia. But the whole TXA thing, I mean, if this is like a massive GI bleed, I would have expected to see something, because the medics were like, oh, would you give TXA in this case? And I don't think I would.
I don't think so. I mean, you have to give me... reason, right? I think to a lot of people, just give me a reason.
Yeah, that's what GI bleed with hypotension is what they were saying. And I was like, right. If I'm thinking GI bleed with hypotension, I'm thinking like a massive hematemesis, or.
I mean, here's the literature. I mean, this is a halted study which is going to come out, right? Yep. Which will give us the answer about GI bleed and TXA, whether TXA works for GI bleed. Because right now, for lower GI bleed, there's not good literature. Cochrane has reviewed this a couple of times, and there's not good literature, not good support. Upper, there is some literature, and initially Cochrane was against it. Now it's more equivocal, because there is. I mean, we can do a journal club on this maybe one day, but there's some papers, but it's not overwhelming. But I think we all agree, though, in the past, if somebody's a massive upper GI bleed, we're probably all going to get TXA, right? And maybe it'll work, maybe it won't work, but we're going to give it. Yeah, and
that was kind of the medic's question. They're like, oh, do we think she's hypotensive from a massive GI bleed? Should we give it? I said, I don't see any evidence of a massive GI bleed here. I mean, I don't know why. Put an ultrasound on her chest just to make sure the heart looked okay and heart looked fine.
Is there a is there like a known contraindication to giving it for an upper GI bleed? Like, would it have hurt her if you had decided to?
I don't think so. I just couldn't convince myself. I'm like Dr. Merlin. I couldn't convince myself that she needed it. I don't think it would have made a difference.
Right. I mean, she wasn't throwing up blood.
The family says that she had been for a couple days. They said intermittently for 3 days, but it was very broken.
I don't know. So what I've done. Yeah. I mean, if I believe the family that she was really throwing, and I said this was bright red blood, that she was really throwing up, and her blood pressure was 60, I probably would have given it. Yeah. If they said, we saw a little blood in the tissue, and we were there all the time, and she's hypertensive, I probably wouldn't. So I probably would have erred on giving it if it seemed like a reasonable story. What would you guys have done? I mean, I would have done the same usual stuff. Yeah. I would have given like fluids and blah, 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 and maybe a pressor and all the usual stuff.
She was awake alert oriented, answering your questions.
She was answering questions. Really? I mean, I spoke to her in Spanish. She answered every question appropriately. She could tell me where 60? She lived, her address.
Blood pressure 60? Mm-hmm.
That's very impressive.
Because when you walk in, she's, lethargic, eyes closed, head rolled to the side. I'm like, does anyone check for a pulse?
Right.
And she had a great pulse in the femoral artery. She had 0 radial pulse. Mm-hmm. Right. And then we checked the pressure, kind of went along.
And we know that's all terrible literature.
I was say, which again goes right along with the clinical pearl that we just put out about pulses. But you could tell she didn't have good distal perfusion, but she somehow was maintaining perfusion to her brain because she was answering questions. And I said, "Hey, show me your left hand," and she goes like this.
Important question in any emergencies: how are you doing? Yeah. And if the answer is good, then I probably got airway, breathing, circulation, stability.
Right.
Right.
I said, "Show me your left hand," and she goes like this. I said, "Show me your right hand," and she goes like this. I said, "Well, she's obviously making conscious decisions." So I said, "We're not gonna rush." I said, "Let's get her to the ambulance. It's an IV
Right.
fluids. I put an ultrasound on
No
her.
reason to get
Yeah.
upset. It's okay.
Yeah.
And
And
her
so that's
blood
why-
pressure's 60, but she's with us. It's good news.
Yeah, and then we
Right?
repeated it, and it was like 70. When we got to the hospital, it was 72, and they were so excited about it. I was
Right.
like, see?
So do you know what happened to her?
No, I don't. I mean, I was actually.
So we
I
got to figure it out for next week.
went to a hospital that doesn't go. That's not within our system.
Right.
So
Well, so we can figure it out, but
yeah,
you know, the question is, did she get scoped?
yeah. I'm curious.
And I guess if she had an upper GI bleed, you could have.
Yeah, I couldn't convince myself enough to do the TXA. I just didn't think it would be benefit her, especially since they said it started 3 days ago. We all know the earlier you give TXA,
Right.
the more effective it's going to
The
be.
good
So
news is
mentally, I could make
upper
that.
GI bleed 75% stops spontaneously with nothing. The doctor doing nothing.
Yeah.
Right. And I mean, then I guess I would have questioned, you know, dark red blood or coffee ground emesis.
They said it
the
was
old coffee
dark.
ground emesis,
Yeah.
which made a lot of GI guys a lot of money because somebody had coffee ground emesis.
Oh,
But
yeah.
the most common cause of coffee ground emesis is nothing.
I was gonna say
The most
coffee.
common cause of peak T waves is nothing, right? Most common cause of severe abdominal pain is nothing, right? Doesn't mean you should ignore any of this, but in all comers, it's going to be nothing. We're not going to either. We're not going to figure it out, and you're going to be okay tomorrow.
Yeah. I had a true coffee ground emesis.
Did you?
They swallowed the entire can of coffee grounds
Right.
in the prison
In the prison?
so they could go to the
Right.
hospital.
That's pretty
Yeah,
smart.
I'm not
I was
surprised.
like, it
Terrible.
smelled like Folgers. I was like, no,
This is lovely.
this is like the best
Just
cheese.
the best part of waking
I remember
up.
being a new attendant going to a bedside for a woman who was probably like 60 years old with blood pressure 50, but she was altered. And she comes in, her blood pressure's 50, and you're looking for like an easy answer. Her husband's there with her, lovely couple. I can actually still picture her. And I couldn't put 2 IVs in, so I go grab a central, somebody grabs me a central line kit, and I put a right IJ in her neck. This is a little bit before ultrasounds. And I'm thinking, why is she hypertensive? Why is she hypertensive? Husband swears, no overdoses, no meds. She's not bradycardic. It's just a sign that she's not bradycardic. She's like a little tachycardic, but she's persistently hypertensive, and I don't know why. She's got no fever. I throw antibiotics at her, right? I threw vancomycin at her because that's what we do. But she had no fever, no recent cough, no recent anything, and it suddenly happened, right? And she's definitely like altered, but she's not good enough to go to CAT scan yet. So I put a cordis in her, I squeezed 2 liters of fluid into her, still persistent hypotension. Put her on a Levophed, right? And her blood pressure comes up to 90. But in the meantime, give her like 2 more liters, lungs stay clear, and she still stays roughly, you know, 70 to 80 to 90 systolic. Don't know what to do, so I actually just called cardiology, and for them to do a bedside echo, I grabbed the machine myself. I thought there was good squeeze, but I got a cardiologist to come right away, and he did an official echo, and maybe detected, and agreed with me that the echo is totally normal. No low motion abdominal persistent hypertension, threw antibiotics at her, and then I'm thinking, well, maybe she has, maybe she, and at the same time I give the antibiotics, I'm like, maybe this is anaphylaxis. She's got no rash anywhere. So I threw like 125 for Cyanmedrol at her, I threw 50 of Benadryl, I threw some Pepsid at her, and I gave her some epi. People weren't doing push dose epi, so I gave her like some sub-Q, or IM, which was kind of silly because she was hypertensive, probably wasn't absorbed well through the muscular, it wasn't absorbed well intramuscularly, so I probably should have given her some IV epi, but that did nothing either. And then she got admitted to the ICU, and I found out 2 days later what was wrong with her. So what do you guys think?
Adrenal
What?
insufficiency?
Huh?
Adrenal insufficiency?
Oh, it's a good answer. Well, I actually gave her steroids too.
Okay.
I gave her hydrocortisone
That's what I was
because
gonna
I know what I was
say.
doing, and I was going to cover
Yeah.
everything. But that's good, right?
Yeah.
So, but you know, she wasn't hypoglycemic, which
Yeah.
would go along with it, but you don't have to be. Her sodium potassium, which is only abnormal in 1/3 of patients who have adrenal insufficiency, that was normal too. And and she wasn't nausea or vomiting, which people oftentimes with adrenal insufficiency do. And she didn't have any abdominal pain, which sometimes people with adrenal insufficiency have, but none of those are 100%. And so what do you think 2 days
She
later?
had a positive Utox?
No, so her Utox was negative.
Calcium channel blocker?
Her husband swore she's
Well,
on
she
no
was like
medication.
hyperglycemic, so, yeah.
She's on no medication.
She would be hyperglycemic though on calcium channel blocker.
So
overdose.
2 days later, the answer was that she took, in a suicide attempt, she took her husband's ACE inhibitor, and she took 60 of them.
Wow.
So in retrospect, I remember thinking, so did I make a mistake in not dropping an NG tube and giving her charcoal? Unexplained persistent hypertension, couldn't figure it out, should I have treated her for an overdose, even though the husband was there and swore she was not depressed at all, not suicidal, nothing?
The question is, how often do you, in general, with known ingestions, drop an NG tube or give someone
Yeah,
charcoal?
activated charcoal.
Right?
Almost
Right.
never.
So you're right.
So,
The
I
answer,
mean,
you're right. But
maybe 10
is
years.
this the woman I should have done it with?
Probably not. I mean, in general, like even people you've seen witnessed and ingestion within a couple hours, we're not even doing this to, because there's just a risk of these patients, aspirating.
So I would have.
you know,
So I
to
would
an
have.
intubator, right?
Right. So I was actually very close to intubating her. I actually had
Sure.
the laryngoscope in my hand, and then after the 2-3 liters in the pressor, she started up a little bit, and I didn't. And we brought her a CAT scan. Her CT was negative too eventually, and. But is this the patient who should have gotten intubated and should have gotten an NG tube? I still remember the case.
Yeah.
But
I'd say you're probably okay if you did it.
yeah. All right. Anything else? Oh, my other pre-hospital case I stopped by somebody was an ALS nosebleed. I always like to stop at ALS nosebleed because I always wonder how you define an ALS nosebleed. And sure enough, this was somebody with a nosebleed. The bleeding was all over the place. Somebody wasn't holding direct pressure well, and somehow an ALS unit got dispatched. So it's like, I don't know if this is an old trick or everybody gets taught this, but you don't have to stand there with your fingers on it. You just take 2 tongue depressors and you tie tape around it and you just put it on the nose,
Yeah.
right?
I
And
feel
I
like
always put it
sometimes
like
that's
face
too-
down.
I feel like sometimes that's too tight.
It depends on where you
Yeah.
put the tape. If you put it higher, it's a little.
Yeah, so I always do that. I mean, and then usually somebody's bending them backwards, I bend them forwards, and I just do this, and then you can walk away. And then if we're there, theoretically, I will, I take cotton balls and I either put cocaine or oxymetazoline, which is Afrinone. I stick it up the nose, and then as a vasoconstrictor, and then I do it with the tongue depressors, right?
I do a mixture of epi,
epi.
epinephrine, and
Right.
a little bit of like.
And in 2018, a little bit of TXA too.
That's what I've done with.
Because we've
some
given a lot of
instances.
TXA for nosebleeds. Larissa had one, right, for a doctor who was actually a pre-hospital patient at her hospital who had a bad nosebleed, and she gave TXA to this OB doctor who never heard of TXA, which is a little concerning. And she was able to stop this bad nosebleed with just some intranasal TXA. I mean, she put it like on some 2x2s or something, and then just push it up the nose, but it worked perfectly. So, I don't stand there and hold it. I actually use a tongue depressor. But everybody learns this in residency, right? And this is not new, right? Okay, we'll do maybe an article in the policy or something, and then I have more to send you guys, and whatever we don't do, we'll just push off to next week. Who wants to do which article first?
I can do the IO cardiac arrest study since
Okay.
that's kind of what the research
That's
project
what,
is on.
Yeah. So we all agree, first of all, that do we all agree that in 2018 there's no need to put a central line in during cardiac arrest?
Yes.
Absolutely.
It's just more risk. You have a big needle. Somebody's going to get stabbed, and to me,
And for what benefit? There's no benefit.
right,
You're taking all this risk for no reason.
right. And as much as we love to do the IO right away, every now and then somebody can get a quick IV and it's okay, right? I mean, if I have 2 large bore IVs, I don't know that everybody needs an IO, right? And 2 large bore IVs just means if one gets pulled, I have a second one in.
Mm-hmm.
Do you guys agree with that? So,
Yep.
Yeah. I
The
agree.
other thing is that people are putting in central lines in the groin for these emergent central lines, and with the IO you can just put it right into the humeral head, and
Right.
I check.
that's how they market their product now, right? In the humeral
Yeah.
head.
I usually check to make sure there's no hardware in there. So if there's it looks like they have a shoulder replacement, I won't put it in that arm.
I guess
But
that's a
other
good
than
point.
that, just put it right in.
Some people, I mean, I think it's a silly, but some people put two in. I've seen people do that.
Oh, why?
And,
Enough.
I don't know, because
Seems
it's
silly.
silliness. It just looks kind of strange when you have 2 in and you go into a hospital. The risk is that when you put somebody on a stretcher, that you'll push on it or pull it out. So it's just something to consider. But all right.
Most of the compression devices are pretty nice because they'll actually put the arms up here over your head, so
Right.
you don't have any
Oh,
interference.
right. We trialed that bone injector gun. You guys know that the big.
Yeah.
We trialed that here. When we trialed the sternal bone injector gun.
Sternal IO.
Yeah, what's that called?
Oh,
Yeah.
There's a name for it. It was actually a cute name. They named it in a way that everybody should remember what it is, and of course I can't remember it. But it was like Sterno IO or something, and that was
Fast
Dr.
responder sternal IO.
And that was Dr. Westrel, but we still use the IO. But he used it a couple of times in a cardiac arrest situation. So go ahead, sorry.
No, that's fine. So This article, we have reviewed it once, just a couple months ago when it first came out, because it was the hottest topic out in Annals of Emergency Medicine. So essentially it's looking at IV and IO access in out-of-hospital cardiac arrest, looking at actual neurologic outcomes. So essentially what they found in this study is that intraosseous IO access is actually associated with lower survival and worse neurologic outcome among patients who survive from out-of-hospital cardiac arrest. Something to point out was this was essentially a secondary analysis of other data sets. So the time frame was 2007 to 2009. So this is almost getting on 10 years old data here. I bring that up because we'll talk about a little bit why that kind of is important, and then also they talk about the favorable neurologic outcome at time of hospital discharge is modified Rankin scale less than or equal to 3, which modified Rankin scale is what we're using now to determine actual neurologic outcome, which is really what we care about. ROSC doesn't matter a whole lot to us, because if you have ROSC, and that's a whole other discussion, but your neurologic outcome is, you have a modified Rankin of 5 or 6, I'm not really sure you're doing too good. So this was a very large study, so what they did was they were looking at patients treated by EMS, ages 18 and older, so every country is a little bit different in terms of what they use. Here we use 18. Non-traumatic out-of-hospital cardiac arrest, and then they were looking at the route of initial IV access, so IO versus IV. And they were excluding patients who had failed attempts at access, so if they started with an IV and then said, oh, we failed, let's go to an IO, that patient was actually excluded. Then they excluded patients that didn't have any vascular access. They were looking at a bunch of different secondary measures in terms of the initial rhythm, was it witnessed, bystander CPR, so there were a lot of different things that they looked into. Again, other things that most out-of-hospital studies don't have is what was the in-hospital treatment, therapeutic hypothermia, did they get fibrinolytics, did they get interventional cath, therapeutic cath, whatever it may be, and then what happened at the time of their discharge. So they were also looking at all attempts at vascular access, so some of the patients had an IO, and then later on during the resuscitation had another form of intravenous or intraosseous access placed. Those patients, because they did have initial access that was successful, were included. Again, they were looking at favorable neurologic outcome, and secondary outcomes were looking at ROSC and survival to hospital discharge. Did you make it or not? They started off with 17,400 patients. They had 13,155 eligible patients. Out of those 13,000, only 5% actually received IO access, and the other that was 660 patients. The other 12,000 patients, 95% all got IV access as their first line. That kind of brings me up to the fact that this is 10 years old data, because now I think, at least in our system, I think it is mostly IO as the first line, which I think shows a paradigm shift in kind of EMS, at least in our system in this area. We'll talk about reasons for that in a minute, but at the time of this study, IV was still the initial route of access. Out of the patients who had it, again, only 5% of the patients had an IO, and 1.5% of those patients had a favorable neurologic outcome as compared to 7.6% of the IV patients. Again, you had a lot more patients. I'll let AJ kind of talk about the statistics and how they had 12,000 versus 600 patients with comparison groups. They did mention, though, that patients that had IO access had a higher proportion of non-shockable rhythms initially. Most of them were not public, and most of them were not witnessed. So we all know that witnessed arrest, bystander CPR, bystander AED, and shockable rhythms all have a more favorable outcome for survival. So I find it interesting that the patients that were set up for the worst outcome also happened to have IOs and then had a bad outcome. Some of the limitations they talk about, one of the things I think is important to us as a fellowship is it specifically mentions the data on the time of vascular access wasn't recorded. So it says they're unclear whether or not there were differences in the time of vascular access. Was one faster than the other? It didn't record times. That's something that we're looking into, and my thought before reading the article or before actually looking into the numbers was an IO is probably faster. you don't have to really think. You don't have to put on a tourniquet. You don't have to look for veins. You literally just find a spot and drill your IO. What we're finding when we're looking through our charts is that that's actually not the case. It's about the same. There's no difference in how long it takes to get an IV versus an IO. And then again, the discussion in this talks about that only 5% received IO, the rest received IV, and they did find a statistically significant difference, and they did a few different, from what it sounds like, from my understanding of the statistics, was they looked at the results using multiple different methods. Is that correct?
A lot of different methods.
Yeah,
They like threw the book of biostats at
that's
the
what it
study.
sounded like to me. It's everything I've ever heard of.
It's
But-
literally everything they could have done.
And
They did.
because they were looking for an answer, or why did they do that?
I mean, they did multiple imputation to fill in missing data, and they used matching they literally matched on every variable they could, and they put that into their own logistic regression model. They just went every single direction to see how sensitive the data was, and massive amount of statistics time went into this, like hundreds of hours. It's quite a lot of stats actually.
So,
Because to fill in all the missing data, and because multiple imputation in and of itself, before you can even like go ahead and to publish it, like I think I did with Dr. Carr's study, you have to check the sensitivity analysis on it, like every single direction, because you don't know if your base there and that you attached to your multiple imputation and how your seeding, which is like the random imputation you're putting into that cell that's missing, is correct. So you have to keep checking it in multiple ways, and it just takes a massive amount of time, like a massive amount of time. So the fact that they did it so often throughout the entire study, and they're not really seeing anything. I mean, if you look at the chart on, let's see,
Figure 3.
is this figure 3? Figure 2?
Figure 2.
You'll see propensity score matched. It's just directly in the middle of all of them, basically, for the most part. And
give me a good definition of propensity score matching.
so propensity score matching is when it's a form of logistic regression, and your outcome is just like treatment or not treatment, and you basically match on all the variables that you want to put into the model. For instance, they matched on all the variables of table 2 besides the outcomes. So age, female, initial rhythm, location, and hospital treatment. You put that onto your model, you match on it, and it predicts your treatment. And then you get a propensity score out of that, you get 2 groups. And then you test your difference again. And so it finds a more approximate difference after you test for that. I mean, I think propensity score matching is becoming a gold standard in my opinion, especially with retrospective data. Yeah, it's very amazing what it does, because it gives you a mathematical like justification that this is our control, this is our treatment, and we have mathematical proof of how similar they are, not just we put them in 2 groups. So yeah.
So did you like the stats?
On this study, it was almost a little overwhelming because they went so many different directions, and they didn't, and it kind of got the same result basically. I mean, if you look at the figures, especially with on figure 2, you'll see that like the difference between a sample of 50 and then our large samples of 600, we're getting like the same OR. And this is because the central limit theorem states that any sample above 30, you're going to start seeing the same pattern, and that's why everything's in the same area. I think it just proves statistical research, and especially with what they're doing. So they can basically go any other route and say it's only going to vary a little bit, which I think is really great.
Does our study add anything that this study doesn't?
Yeah, I think that it kind of.
Well, it's looking at more recent data.
I say I think
That's the big
it
thing.
provides more recent data, and second, we're actually tracking the time to getting the access.
Right. So,
which
do you
wasn't
believe
done
these
before.
results?
You know, this is my question. I guess I will hear in a minute once I ask AJ. Does comparing 12,100 to 600? I feel like that's just such a drastic group, like such different groups.
Well-
Can you take that seriously? I
Well,
mean,
when you compare it, like let's see on like table 1, 660 to 12,495.
Yeah.
When what they're doing when they're matching that entire group with great accuracy to the 660, because it goes down to what, 500 and something, 558. So using a propensity score model, the 2 groups are going to be extremely similar in characteristic on like all these characteristics that they matched on. So if there's another confounder that we don't know that's in the model that's leading to improved survival, that we just didn't put in the model, that could be it. So
So how many? Did they do a power calculation? And I mean, because they didn't need to have 12,000
I didn't see
people,
that.
Yeah, that's why I was curious. That's kind of what I
right?
think.
Like,
threw
why
me
did they just do a
off.
power calculation, see how big the sample size needed to be, and then stop?
Because they had they had 945 people in the IV group with a favorable neurologic outcome, and only 10 in the
Right.
IO group. But of course, you're only going to
it
have
looks
10.
like they just pulled all the charts and just studied it. Because
Yeah.
it
Right.
doesn't say that it. That
But I'm thinking about all the work they had to do. They didn't have to do so much work, right? If they did their power calculation, they could have just
True, yeah. Because I think that's a great example. Because especially with the figures showing, like a group of 50 is having the similar result as a group of 600.
Right.
So the power, because power is calculated on two things: sample size and the difference between groups. So that if the difference between groups, the variance is low, like you see in the size of 50 that you did multiple mutation on, you can infer that to a group of 600 or a group of 12,000. So they had low variance in their multiple mutation group.
I mean, so then to I guess go back to answering the question. I think that it could be accurate because, especially looking at what we know now in terms of IV versus IO taking about the same amount of time, I think it comes down to paramedic experience and comfort. If you feel that you're going to get an IV just as quickly as it's going to take you to get an IO, I mean, IV is the right way. But if you're going to have 3 failed attempts before you decide to go for an IO, I mean, I still think the primary thing needs to be to focus on the right things that we know work.
What about the outcomes difference between the two?
What do you mean? In terms of the survivable outcome?
Yeah.
So I think that
I don't know, I don't think
the people that they use the IO were people
sicker.
who were sicker,
Right.
essentially. Like when I first started using IO in cardiac arrest, I was trained to start an IV, so I would go for the IV.
So the
first.
difference exists because the IO patients are sicker.
They're sicker, and they're also putting the IO in. The
And,
Okay.
and it even mentioned that a lot of the patients that had the IO were all the things that we know have a significantly decreased chance of survival anyways. I mean, non-witnessed, non-shockable rhythm without any bystander CPR.
Exactly.
So, I mean, those are all, I don't care if you have an IV or an IO, it doesn't really matter what you have. Those patients have a very low likelihood of survival anyways.
The ideal
But-
study would be first attempt IO, first attempt IV, success. And look at
and all
that cohort.
and also all comers,
All
not
comers.
like, oh, I just happen to want to do this today.
But you'll see a subset of population only that have first attempt IO in all comers. It's going to be a pretty narrowed subset of patient population that you're going to have.
It also matters if you have one medic or 2 medics. So when I first started as a medic, I was single medic alone. So I prioritized. I intubated first. I did all the wrong things, but it was the right thing at the time. I intubated first. Someone was doing compressions. I started an IV. I pushed my meds.
You put on mask trousers so you get some calcium.
Threw the mask pants on, and but nowadays I would drill the IO, focus on compressions, put a secondary airway, and then intubate on the back end, like when I'm transporting my Ross. So it's a completely different field right now in the last 5 years than it was 10 years ago.
Right.
Yeah, that's what it says. That it says equipment for IO access was relatively new in the time frame for the 2007-2009 data. People are now very familiar, very quick with it.
So the results will be very different today, is
I
what
think,
you're saying.
yeah, and that's why I wanted to look at more.
Why
I think-
take them so long to publish this?
Stats.
Yeah, they've been working on stats for 9 years.
Stats took 9 years?
Yeah.
No. Come on,
I don't know,
AJ
AJ,
could have
what
done
do you
this in 6 hours. What do you think?
This would take me up towards 100.
100 hours?
Yeah, to do this study, it would take a
All
while.
right, but not 9 years.
Not 9 years. No, it'd take like 2 weeks.
2 weeks.
So him doing it 2 weeks would be us about
9 years.
Yeah.
If we did it
Something
ourselves.
happened, by the way. We just don't know what it is. Something happened along the way of publication,
Yeah.
right?
Yeah. Well, and then, so other things that the study mentioned was we don't know what the in-hospital treatments necessarily were. Did the patients require transfer to other facilities? I mean, what if
Yeah.
they went to a place that didn't have a cath lab and then an hour later they had a STEMI, then they
Yeah,
got transferred?
I see your point.
So I think there's a lot of confound. At least my mind can go running with this study in terms of things that have happened. And
What do you think the main confounder is?
I think the main confounder
Like
is
that they didn't put in table 2.
Oh, I'll have to look at exactly what table
I have
2
it up
says.
here,
But
so-
essentially, what I want to know is, which I talked about was the shockable, non-shockable rhythms. I mean,
I mean, overall, did the sicker people get the IOs?
Yeah,
You know?
I think that's the big
And that's
thing.
what I think.
Like a clinical impression or like overall.
And just
So we-
sheer numbers wise, if you have more people getting IVs, then more people from that group are gonna survive just based on like numbers. You know what
Right.
I'm saying? Like you just have more people.
It's hard to get IVs in sick people because their veins collapse, so we oftentimes go to IO, or we go to IO after IV. You know, the nurses try the IVs real quick, and then the nurse can't do the IO, so at least around here, so we have to put the IO in, and it's usually afterwards. The patient's a little bit sicker by the time we put it in.
And then on top of that, we're getting the access to give. Sometimes we're giving fluid, but I mean, everyone wants to do all of our epi, which we just reviewed.
Right, so all the things we're
What
giving
does
through
it
the
do?
IO doesn't really work anyway.
Exactly,
That's why I
so-
had trouble believing that there would ever be a difference. All you do is you
Yeah.
get access. Right?
Exactly, they're just getting access, hoping that if they survive, you can use it for something.
The only thing I
Right.
could
I
think
mean,
of is
in my
like
opinion.
calcium and hyperkalemia.
Right, but,
something
but it
like
must have been a
that.
small percent of people who are hyperkalemic.
Exactly,
The
or
whole
I mean,
thing.
volume.
But we never know because we don't routinely get potassiums
Yeah, and I'm
in
hoping that they
cardiac
have a
arrest.
permacath, and if so, just, there you got access. I'm just going to put their calcium
Right.
in there.
Except the risk is the permacath is clotted off because they
Yeah.
are in cardiac arrest or they're hypertensive.
Mhm.
Permacath is clotted off. Right?
Yeah.
It'll definitely take a longer time to access that than
Right, right.
to get an IO or IV.
So, all right, you want to do one more?
Do you want an article
Sure.
or a
I can do a
policy?
policy
All right, do
since it's a
policy.
little different. So, I'm going to review the spinal motion restriction policy in the trauma patient.
I think it was the last one they put out, right? So I tried to get all the last policies that were put out by different organizations.
Yeah, so this was from the American College of Surgeons Committee on Trauma and ACEP, and it was put out just in 2018. They reviewed what we called today SMR and the whole concept of introducing SMR, spinal motion restriction, as opposed to full backboard and collaring to in patients with suspected spinal injuries. It was actually May 23rd that they put this out, so it's pretty recent.
And people are talking about this policy like all over social media, right?
Right. I actually published an article on EM Docs, got
Right.
5,000 shares, so very happy about that. But I was actually not 100% crazy about this. So they just talked about in general the goal of spinal motion restriction or spinal immobilization is to prevent further injuries, unwanted movement of the spine, all things we know. The fear being that you have a stable fracture or someone who's potentially neurologically intact, and then during transport or during extrication, you transfer that to an unstable fracture and causes neurological deficits. So in their policy, they states that the indications for spinal motion restriction, they define moving from backboards to, and a number of different attempts, either like a scoop stretcher, padded splint, vacuum splint, along with a cervical collar. Should be done in blunt trauma patients who are acutely altered, have any midline neck tenderness, focal neurologic deficits, spinal deformities, or any distracting injuries. So, your femur fractures, hip fractures, amputations, big injuries. They mentioned, which is kind of important, that cervical collar needs to be appropriately sized, because I know we see this all the time. Collars that are up by people's eyes or
Right.
hanging off to the side. And they said that, in each case you need to weigh the risks of manipulation against the benefit of device removal. So if they're in a position already, maybe with a towel roll or something, is it worth it to try to reach in and,
Right.
move them onto a board? They also state, which is pretty important, that there's no role for this policy in penetrating trauma patients. So your gunshot wound to the chest, to the head, that's isolated, we don't put these people in collars.
Right.
All you're
So-
doing is obstructing the airway.
And we've talked about this before, several papers that were published, about two, I think, good ones, that say isolated GSW to the head doesn't need a C-collar. But I we've talked about this, but I'm a big believer that, it's very difficult message to send to EMS. Don't put these collars on these people, do put collars on these people.
Right,
An
it gets
occasional
confusing.
extra collar with a GSW to the head is not such a bad thing, right? It's
Right.
right, because we have the right to take it off, and that's totally okay, right? The mistake we make is we don't tell EMS why we're taking it off, so they think they made the mistake putting it on, and an extra collar and a GSW that has okay.
The other thing they just talked about briefly was pediatrics. So based on the PCARM policy, they state that you should be applying to college to pediatric patients who have any complaint of neck pain, neurological deficit, torticollis, which I thought was interesting. And
Yeah, I think it's silly.
yeah, I'm a
Everybody's
little
got some torticollis, right?
confused about that. And anyone involving a high impact injury or substantial torso injury. And I guess I wasn't exactly sure why they said that in particular for pediatrics. It seemed, I'm not sure that was.
I mean, I thought it was too big a generalization. But the one thing I've
agree.
noticed about these policies is even NAMSP's last policy about spinal motion restriction wasn't that great, and I was disappointed. But then I realized that making policies is about politics and making lots of different people happy
Right.
from lots of different organizations, and a lot of people who are sitting around the table for these policies don't necessarily agree with the final product.
Right.
But you have to compromise your beliefs. I remember when we did a big article about kids who were having vomiting after hitting their head, and how many times you tell the parents to go home, and if you vomit more than X number of times, then bring the kid back and we'll do a head CAT scan. And we did a big study which showed it was total BS, that vomiting has nothing to do with intracranial bleeds, right? Nothing. So then the policy came out 6 months later by the American Academy of Pediatrics that said two things. One is if you vomit more than 2 times, you should do a CAT scan of the head. Even after the study came out that said that's not true. And this was a couple of years ago now, it said you should do skull films. After we've proven that skull films don't make a difference.
Makes me cringe.
After we've proven it, then they still recommended it, and it makes no sense. But a lot of people weren't happy with the policy. But again, you're making a lot of people happy, so at least it's heading in the right direction, right? That we have to be
Yeah.
happy about that.
The thing that I just makes
But that's not what I tell people. I tell people my SMR policies are the same no matter how old you are.
right. The thing in particular that made me cringe the most about this article is that they're recommending to use backboards. They're saying that you should be transferring patient over using some sort of long stabilizing device still, and it's
Well,
they're still
transferring over
moving.
is different from the
Yeah.
complete utilization of it, right?
And in some cases, they said to leave people on.
Right.
So I was a little surprised.
And
to see
that's
that.
kind of silly. But again, it's again, I used to throw my fist up saying this is a crime, but now I say we're heading in the right direction, right? And I bet, and if you look at everybody who writes these policies, I bet a bunch of them didn't agree with this.
Right.
And so I agree. I think the best literature can never keep up with policies. That's why some of those policies are dangerous. Because this is not what I would have some squad do, but as
Right.
as a medical director, you can tell a squad to do whatever you want to, right?
They did mention to pad shoulders more in children and adults, and I think that's
Right.
an important thing. So
Right.
even if you have someone telling you this is what you need to do, at least do it the
Right.
right way. And
Because that little old lady's been kyphotic for 20 years. When you lie her flat, no wonder she's getting sicker, right?
Yeah.
No wonder she's short of breath. No wonder, now her back hurts really bad. Like, it's not surprising, right, that
Right.
they're getting sicker, right? You would too, right? I put you on a backboard, and if you're not kyphotic, and we all are, then we're going to have more pain, and we're going to get more imaging, and we're going to get more radiation, and we're going to get more cancer.
It's like, why are they point tenders? Because they were on the backboard.
Right. I
Right.
wonder how many people got intubated over the years because somebody lied them flat when they haven't lied flat for decades, and now they're getting really short of breath, and somebody jumped the gun and intubated them, and there was trauma to the airway or something bad because
or aspiration.
or aspiration, right? Or obviously skin breakdown, or all the
So in EMT school, they used to teach us to pad, but it would take you 30 minutes, 45 minutes to properly secure someone to the backboard.
right.
But I mean, no one does that.
And a bleeding liver and spleen for 20-30 minutes is not a good thing. Right.
Difference between life and death.
Right.
I think in a lot of these patients, if they're stable and your ABCs are intact, everything like that, take the time because
Right.
you want to get them there with
Right.
a
We used to
Right.
hang
Stable.
people from the backboards after you strapped them
Of
into
course.
Oh, yeah.
Right. Of course.
The worst thing, though, that I always thought was when they would secure the head very securely to the backboard, but nothing else.
Right.
So
Yeah.
now you're just making a little pendulum on their cervical
Right.
spines.
Or, we have to remember that if you're carrying somebody across a football field on a longboard, because that's the only device you have, right, which this shouldn't be the case, but does, you still have to strap them down, right,
Yeah.
because they will fall when you carry them, right? So we don't want you to keep the patient on the backboard, but we want you to tie them down to the backboard
It's a
so they don't.
transporting device, not a.
Right.
right, an extrication device.
Right. But buy reef stretchers and buy scoop stretchers and buy or at least dust them off because they're
Right.
somewhere you just haven't used them.
They have some new scoops that are great. They break apart into 2 pieces. They're made
Right.
out of plastic. They're washable.
I do recognize that some of these things are a little expensive,
Yeah, of course.
so you have to. But there is a machine actually. Places used to have to clean laundries, right? That machine. I forget. I used how much
It's
it
like a
cost.
washing machine.
It's very expensive. You want to do one more policy?
Sure.
Which policy? Janae, which policy?
I had the EMS director's policy,
Okay.
which was, I mean, so I don't know if you've noticed, but I always print out my articles instead of doing it on the computer. I basically just highlighted the entire article because I felt like everything they said was important and it all made sense. I'm not really sure.
That's a good policy then.
Right, yeah.
That's what you want. No
I
fluff.
mean, it basically just walks through the roles of the physician the title of it is the role of physician medical director in emergency medical services leadership, and it walks through all the things that are important,
So
intricately
just say
familiar.
who wrote the policy and what year is it from?
Oh, sure. So it was copyrighted in 2018. Yeah, so this was in March 2018, and then I don't know.
ASAP.
Yeah, I was like, I don't think that there was a specific author. It was in the American College of Emergency Physicians. So
It's an ASAP
policy. Yeah. I mean, and it all makes sense. I mean, actively direct and lead the clinical performance in an EMS system. Be involved in the system design and outcomes and operations. It mentions that you should be able to monitor, influence issues in funding and reimbursement and government regulations. So I mean, it's a big hefty job. One of the things that I thought was interesting that they specifically put in here was that you should be an advocate for mental physical welfare of patients and EMS professionals, including patient safety initiatives, EMS system designs that incorporate appropriate sleep-wake work cycles and maximum duty hours, because that's something that's I don't want to say it's a hot button topic, but it's something that's actively changed in residencies across the country in the last couple of years, and I think it's cool and it's important that they're recognizing that it's important for pre-hospital people as well. And they also even go so far as to mention like that you should have liability protection and discussing a specific directors and officers policy that you should
Right.
have.
And that's coming up. Our lecture from our medical liability
Yeah.
insurance experts coming up. I have to put it on the calendar.
Cool.
Said HSAP should give us money too, so I like
Yeah, it
that.
does say that
was a good
that
part.
ASAP supports the research and efforts that are involved in like pre-hospital stuff in general, because it's important to figure things out before the hospital affects what we do in the hospital and in the emergency
Right.
department. So
And in fact, when I've made up job descriptions, because any good CEO will say to you when they're going to create a new line item in a budget, will say, "Can you write up a job description for yourself?" And so you can't just don't sit down and make stuff up because you're a smart person. You take it from somewhere. And what I've oftentimes taken it from is either ASAP or NAMSP, and and I include everything for like a system medical director, a chief medical officer, and because you're making up a job title for not just for yourself, but for the next 100 years after you leave, right? So you make it up, and you want it to be generalizable to everybody who applies. So like one thing I say is the chief medical officer or medical director must be at least board eligible or board certified EMS, and then you put as time goes on must be board certified, not just board eligible, must have X number of years experience, and stuff about having an EMS background, et cetera, et cetera. So you restrict who can do it. It can't just be non-tonal. And then I always like to add, you have to complete an EMS fellowship, so you can't have grandfathered in, which not everybody likes who's older, but it's the way of the future, right? Because I always say you wouldn't have somebody be a cardiologist based upon grandfathering in, right? So it shouldn't be for EMS either.
Makes sense.
And that's the way with the future. So when I write policies now, I'm thinking I'm writing this for the next 100 years. They can't just be boarded in it; they have to have completed a fellowship in it, right? Anything else with the policy?
One thing I thought was interesting too is they said that communication specialists should also be included
Yeah.
in all this. So I think dispatchers oftentimes get left out of the whole realm of everything. And in New Jersey, everything's run by guide cards, and they're not always up to date with the times. So I think that's very important.
Right.
You have something else, Janae?
no, I think it's everything that we're working towards. It's why we're here. But it's a lot, and it just goes to show that there's a lot involved in what we're
Right.
training to do.
Right. but it's gotten to the point where it's board certification, its own specialty, et cetera, et
Right,
cetera.
right.
Right. That's why we have to keep saying this over and over again. You can't just have a regular emergency physician in the back of your plane, because that's not good enough. You have to have somebody who's trained in the right specialty, and what we do is completely different from emergency medicine. I was in a meeting yesterday in a different state, and by a lot of smart people in a county-based EMS system, and they were like, "Oh, our medical director is so and so, who's an emergency medicine doctor," as if they were saying like, "This is a big deal. We got an ER doctor, not just the radiologist, to be our medical director." So of course, I said, "Oh, that's fantastic. That's great." And then I kind of went into what an EMS physician is, and you could tell like they were kind of quiet, like maybe this wasn't as good as we thought it was, because it's the right specialty, et cetera, et cetera. Okay, so we're going to stop. Thanks for tuning in. We will see everybody next week.